Again, welcome everyone, and thank you so much for joining us today to observe the International Day of Zero Tolerance for Female Genital Mutilation. I'm Dr. Aparna Sridhar. I represent International Federation of Gynaecology and Obstetrics. I'm the Division Director for Sexual Reproductive Health and Rights at FIGO, and I'm joined by Anush Agbalian, who is the Head of Advocacy and Policy at Orchid Project. We welcome you on behalf of FIGO, Orchid Project, and International Federation of Medical Students Association. We're so grateful for your presence and commitment to advancing awareness, dialogue, and action to end female genital mutilation and to support health, dignity, and human rights of girls and women across this world. As all of you may know, female genital mutilation refers to all procedures that involve partial or total removal of external female genitalia. It's a form of violence rooted in gender inequality and social norms, and it has no health benefits. FGM can cause immediate as well as long-term consequences that can be really harmful. Lots of international frameworks condemn FGM as a violation of human rights and a serious public health concern. World Health Organization, which is represented in this panel, calls for a multi-sectorial approach combining health system strengthening, community engagement, education, survivor-centered care, and strong legal and policy framework to prevent FGM and to support those who need. Today, we are focusing on the role of healthcare providers who can play a critical role in prevention, advocacy, and compassionate care for survivors. Today's webinar is an opportunity to learn, reflect, and commit to zero tolerance. We want to work together towards a future where every girl and woman can live free of harm. Thank you so much for being a part of this important conversation. Over to you, Anush.
Hi, everyone, and thank you so much for joining us today. So my name is Anusha Gabalian. I am head of the advocacy and policy at Orchid Project, an international NGO dedicated solely to ending female genital mutilation globally. So before we begin, I'd like to give a brief content warning. Some of the discussions today may be distressing or triggering for anyone, but particularly for survivors of any form of gender-based violence. So if at any point you feel overwhelmed, or please step away if needed, take a moment and engage at a pace that feels right for you. So just quickly over the objectives of today's webinar. As Aparna already mentioned, indeed, female genital mutilation is one of the most severe forms of violence against women and girls, and it's rooted in patriarchy and control over women's bodies. But it is also a profound global health concern, causing lifelong physical and psychological harm for millions of women and girls around the world. And in this webinar, we would like to address it as such, as FGM, as a global health crisis. We also, in this conversation, want to look at the role of health professionals that extends beyond the care and treatment to leadership in setting standards, leadership in challenging medicalisation, and leadership in ensuring that care that is provided to survivors is ethical and survivor-centered. And ultimately, our focus today is on how the health sector can move from the guidance to action, mobilizing current and future health professionals to act as change agents and opinion leaders. I'm sure Christina is going to talk about it today. That's my favorite thing, opinion leaders as from health workers. So in terms of agenda today, we have with us a really inspiring lineup of experts and advocates. So we will hear first from the panel. We have a lot of people, so we'll try to be on time. And time permitting, we will have a short Q&A in the end. A few housekeeping notes. So in the bottom of the screen, the toolbar, you will see the CC button, the captions. So the captions are enabled if you want to see the transcription of the of the conversation, you can click the CC button in the bottom. Hopefully for those who are not native speakers, that will make the conversation a bit easier to follow. You'll also be able to post questions in the Q&A box. There is a question box with a question mark in the bottom. You can start posting your questions throughout or wait until the end to post them there. And then, as the final note, feel free to introduce yourself in the chat. Where are you from, if you want to, so we will know who we are speaking to today. And thank you. I see people already doing that. Wonderful. And then to start us off and to ground this conversation, we'll begin with the global picture, the scale, the geography, the patterns, and the trends of FGMC worldwide. And with that, I would like to introduce my colleague, Sean Callahan. Sean is the head of research at Orchid Project. He has worked for over 30 years in social justice, activism in Africa, Asia, and Middle East. Yes, there you are, Sean. So, Sean, let me start with you and first to ask you to talk us very briefly through the FGM global prevalence and trends. And I know I'm asking you to do the impossible by keeping it brief, but thank you. Over to you.
Thanks, Anush. And hi, everyone. Really great to be with you. I'm going to pull up a couple of slides just to be able to help you get your head around the numbers. 230 million women worldwide are impacted by FGM. About 4 million girls each year are subjected to the practice. Sort of 2/3 in Africa, a third in Asia, and then some in the Middle East, and then, of course, into the diaspora communities in Europe, in North America, in Australia, and so on. Giving you a sense of the prevalence per country, the darker reds a higher prevalence. So you can see it skews towards the Horn of Africa and again across into West Africa and then down into Southeast Asia. The slightly purpley ones are where there's anecdotal evidence of or smaller studies of the practice. Apana introduced FGM using the WHO definition, and it's important to have a sense of the fact that it's more than just one specific type of FGM, and so the four types of FGM as defined by WHO: type 1 clitoridectomy, type 2 excision, type 3 infibulation, and type 4 piercing, incising, pricking, and so on. And different communities practice FGM in different ways, and so that's really why this is important. And you can see sort of the global distribution across the world that Africa is predominantly type 2 and 3. Asia is predominantly type 1 and 4. Middle East is predominantly type 2. And so having a sense of that is really important. And particularly type 3 is more predominant in that northeast corner of Africa, Sudan, Somalia, Eritrea. Also, the age at which FGM takes place varies incredibly from the first few weeks of life in places like Nigeria and Indonesia and Yemen through to teenagers and that sort of transition into womanhood in places like Kenya and Sierra Leone. And so, in the clinical setting, really understanding what type am I expecting to see or experience in the clinic, and at what age would these girls be at risk is a really key piece of the puzzle for you to have your head around. And then just wrapping up to say, medicalisation, Anush mentioned it, is a growing issue in FGM, where the practice is practiced by medical practitioners, particularly in those three countries that are highlighted, Egypt, Sudan, and Indonesia, where most FGM is conducted by health professionals, and there are other places as well which are coming up and where you see more of it happening amongst health professionals. Just a quick point on that. Egypt is mostly doctors who are performing FGM. Sudan is more nurses and midwives. Indonesia is almost all midwives. And so, again, just thinking about in the clinical situation, who are you seeing? What are you expecting? Back to you, Anush.
Thank you, Sean. Sorry, I'm trying to unmute myself. So thank you so much for this quick background. And if I have to ask you one quick follow-up question, and if a health professional only remembers one insight from the global data that you just shared, what should it be and why?
Yeah, I think that point that I made around age and type, really getting your head around that, because that's going to look fundamentally different in the clinic. And so just knowing in the context where you are, what kind of FGM would you expect to see? At what age would you expect to see that? That's really the key here. Girls at certain ages would not be at risk in some communities and are already past the age of cutting in other communities. So yeah,
Thank you, Sean.
thank
Thank
you.
you. That was great, Sean. And I think it's always nice to have some visuals onto this type of data that we had. So this was really good. I think now we're going to transition from data to lived reality. And I think it was really powerful for me when I actually had the experience of hearing from someone who was a survivor. So now I am so proud to introduce Fatou Balde, who is an internationally recognized human rights advocate, FGM survivor, and the founder and executive director of Women in Liberation and Leadership, WIL, an organization working to end FGM and gender-based violence by 2030. Based in the Gambia and globally engaged, Fatou leads survivor-centered efforts through education, policy reform, legal advocacy, and community engagement. I met Fatou when she was in Los Angeles and she was being honored named as the Time Woman of the Year 2025 and the Time 100 Most Influential Person. And as well as she received the ALBI Award, the International Women of Courage Award, and multiple international human rights honors. Appointed MBE in 2020, Fatou has testified before national bodies in the UK, in Gambia, and remains so deeply committed to breaking cycles of harm, both globally and within her own family. Fatou, thank you so much for being here. And I think from your perspective as a survivor, as an advocate, can you please tell us the physical and psychological impacts and why health professionals can make a difference in this process?
Thank you. Thank you for inviting me to speak today. And as you mentioned, I'm really pleased to join this conversation, not just as an advocate, but also a survivor of FGM myself. FGM leaves deep marks, both physically and psychologically. Physically, survivors may live with chronic pain, infections, complications during childbirth and pregnancy, as well as sexual health challenges. Psychologically, the impacts are often invisible but profound. They include anxiety, depression, post traumatic stress, and a sense of betrayal because this was something done to us as children and often by people we trusted. It is therefore important to remember that FGM is not just a one time event, it is a childhood trauma that survivors carry into adulthood. I think one of the biggest challenges is that many survivors do not connect their health complications to FGM. A woman may struggle, for example, to understand that repeated infections or painful menstruation may be linked to their experience of FGM because she has been never told and she doesn't realize that these consequences are linked to the procedure. And this is also compounded by the fact that in many places where FGM is practiced, there is a big culture of silence around the practice. And also, many of us from when we were caught or when we underwent this procedure, we were raised not to speak about FGM at all. So it is normalized, it is hidden, and it's also treated as something that should never be questioned. And that silence continues into our adulthood, making it really difficult for survivors to seek care or even name what happened to them. So often in healthcare settings, we understand, as the previous speaker highlighted the different forms of FGM. You would find that for some survivors, they just have a local terminology of the practice, and that's what they understand. And using certain languages may not be something that they would relate to as a procedure that has happened to them. So language really matters here. And just to highlight again that not every survivor will recognize the term FGM. Some may know it as a cut, some may know it as circumcision or a local word. So if health professionals use techniques, they should use it with sensitivity. Survivors may feel alienated or misunderstood sometimes. So meeting people where they are with words they understand is a small but also very powerful step in allowing survivors to talk about FGM. And again, this is why healthcare professionals are so critical in both the prevention, care, and accountability of FGM. You are often the first point of contact when survivors speak or even ask for help. The way that healthcare providers respond can either open the door to healing or reinforce silence and shame. Therefore, empathy, understanding, and non-judgmental attitudes are essential. Survivors need to feel safe enough to share their experiences without fear of blame or stigma. Thank you. And over
Wow.
to you.
Of course, of course. Thank you so much. I think your words resonated with me. Meeting people where they are. We have the power to heal versus we have the power to shut them down by putting them to shame. So it's so important that that empathy and that non-judgmental framework comes into picture when we actually see a patient or see a person or a survivor in front of us. And there is a lot from healthcare providers that we can learn and kind of keep going. Thank you for bringing that perspective to us. And we are very, very grateful. Hopefully there will be more Q&A over in the end. Anush, do you want to take over?
Yes, thank you so much, Fatou. It's always an inspiration to listen to you. So no matter how many times. We were supposed to also have with us Leila Hussein, who is the director of global advocacy at the Girl Generation and also a psychotherapist. Unfortunately, Leila is airborne, so she was supposed to be with us, but she is flying, and I know she would have loved to be here. And then maybe if I have to say one message on her behalf, I think it would be how important it is to the power of words and the language we use, not to minimize what FGM survivors have gone through. So to call it for what it is, which is a violence against women and girls. So if I had to say one thing, that would be, I'm sure, something that Leila would have said. But yeah, we wish her good luck in landing.
All right. So moving over, I think from the survivor experience, I think we're going to move up to the health sector leadership and accountability. I'm going to introduce my own colleague, Dr. Priya Soma Pillai, who is a professor and head of the department of Obstetrics and Gynaecology and Deputy Dean, Stakeholder Relations in the Faculty of Health Sciences at the University of Pretoria, South Africa. I introduce her as the Vice President of the International Federation of Gynecology and Obstetrics, FIGO, our organization that we both represent together. Priya is a maternal fetal medicine subspecialist, and she has a special interest in managing high-risk pregnancies and particularly women with cardiac disorders, hypertensive disorders. She has served as the member of South Africa National Committee on the Confidential Equity to Maternal Death from 2011 to 2020. She was chapter lead on deaths due to medical diseases in pregnancy, a lot of experience in maternal health. Today, she joins us to represent FIGO. FIGO has been very clear in its clinical and ethical guidance on FGM, particularly through a recent statement that we all produced together. Dr. Priya, where do you see the biggest gap today? Is it policy, accountability, implementation? And what do organizations that we represent, such as FIGO, have in like closing this gap and working towards this zero tolerance for FGM? Over to you.
Thank you, Aparna. Good afternoon, colleagues. I want to start by just echoing what Aparna has said, and I suggest you please look at our FIGO website and look at our position statement on FGM, which was published in September last year. So in terms of closing the gap and how health systems should respond, I think it's important that we move beyond the rhetorical condemnation of FGM, and we should adopt a whole system rights-based response. And this should include integrating prevention, accountability, and survivor-centered care. And one thing that our FIGO statement talks about is zero tolerance to FGM, including the medicalisation. So I think health systems must explicitly prohibit FGM in all forms, including procedures carried out by healthcare workers under the guise of harm reduction. I think that is quite important from a national body perspective. It's also important to include FGM into routine healthcare services. I think we need to capacitate and strengthen our health workforce. We need to develop the clinical skills and assist our clinicians in managing complications. This should include managing trauma and person-centered communication skills. We need to provide ethical clarity on how this condition should be managed. And there should be awareness about referral pathways and legal obligations. So survivors should then be exposed to a holistic type of care. So from the FIGO leadership, I would like to call on national OBGYN societies and clinicians to act as leaders, advocates, and ethical gatekeepers. And we should do this by publicly condemning FGM and the medicalisation of FGM. We should encourage all our national societies to issue national position statements and guidelines. We should act as visible champions in communities and professional spaces, engage with faith and community leaders to challenge some of the misconceptions. And I think as healthcare workers, we should refuse to perform FGM under any circumstances. And we should support survivors with the dignity, respect, and confidentiality that they deserve. Thank you, Aparna.
Thank you so much, Priya. I echo all that, and I think our FIGO FGM statement is online, and it is easily accessible through our website, and I'll try to put that in the chat as well. And again, thank you so much for being in the leadership position of an organization which stands behind us to end medicalisation and more hands to join, more work to do together. Thank you, Priya. Anush, over to you.
Thank you so much, and thank you, Dr. Priya. I think I wanted to reiterate the important message you also mentioned in your speech is about condemning FGM in any of its form, and particularly around medicalisation, FGM performed by medical professionals under the guise of harm reduction. That's really important to address. And thank you for your call as well to health professionals to be leaders in the communities and in the professional spaces. I think it's really important. So thank you. So we've heard how professional bodies such as FIGO can set standards and drive leadership and accountability. And I'd now like to turn to the global normative guidance that underpins this important work and invite Cristina Palito to share her perspective. And we have Cristina. So Cristina Polito is a scientist at the World Health Organization, and I'll try to pronounce the full name, the Human Reproduction Program, where she leads the portfolio on harmful practices, including FGM and child marriage. Her work focuses on the development, testing, and integration of evidence-based approaches that strengthen health systems and promote gender equality and rights. She has more than 2 decades of experience in research and programming on gender-based violence, harmful practices, and reproductive health. And she's always a very important ally to us in this work. So thank you so much, Cristina, for joining us. My first question to you, Cristina, is according to WHO recommendations, what are some of the key actions that the health sector can take to end FGM and support women and girls who have undergone this form of violence?
Thank you, Anush, and it's really a pleasure to be here and to follow on some of these really powerful remarks that we've already heard. And thanks for this question. So we use a public health approach, and what I mean by that is that we address the issue from both a prevention perspective, but also, as has been mentioned, to ensure high quality care for women and girls affected, and also to ensure that their rights are upheld and that they receive the services that they need in a very person-centered and survivor-centered way. So FGM, there are important opportunities for health workers to address FGM. The health system can be an entry point for reaching women who come in for routine services. And the health workers themselves are really operating at this intersection between the communities that they serve and the health system. So using that important role, we've really worked a lot to develop resources for health workers on how they can advocate against FGM in the context of providing routine or even specialized care. So health workers can be opinion leaders. We know that what they say is well respected, and that the clients and patients that they serve can often take the advice that they give and incorporate that into their lives. So we had this as a hypothesis, and we developed materials, and we tested this, and we did find that if health workers if we can work with them to address the values that they hold, the beliefs that they hold around FGM, to work with them to not perform FGM, and then also to go to the other end of the spectrum to actually advocate against it. And when we tested this, we found that it was quite an effective approach, that health workers learned the skills that they needed in person-centered communication, in advocating for prevention, and that more importantly, that women seeking services from them were less likely to support FGM following this exposure to a health worker who had been trained in this approach. So this is really exciting and innovative, and we're really working with partners to try to scale this up and make sure that these kinds of resources can reach a lot of people. This evidence is also incorporated into our latest guideline, which was launched last year. And the importance of training health workers in prevention and in care is a really strong element of the guidelines. There's also another element around ensuring that there are codes of conduct in place so that health workers who perform FGM have some sort of consequences for that action. Either they can lose their license or be fined or have some other punitive action. I mean, they're supposed to be there to do no harm, to support the health and rights of those who are seeking care from them. So this is the issue of medicalisation, which has come up from the other speakers, is really an important one in this process of trying to prevent FGM. In addition, the guidelines recognize that what needs to happen to prevent FGM it must happen outside of the health sector as well. So there's recommendations on ensuring that we engage communities with accurate information on their health and on health risks, and that it's done in a contextually appropriate and in a sensitive way. There are also recommendations on the importance of laws and policies, and these laws and policies really put in place some of the human rights principles, but at a national or subnational level. And there are also recommendations around how to manage the health complications. And these can include complications to women's psychological health as well as their sexual health. And the guidelines explain how health workers can ensure this, and as well as how to manage complications that may be due to the type 3 FGM and the defibrillation that's needed. So this document, this guideline becomes a blueprint for action for countries to take, and it really can guide a health sector response, but also more holistically a multi-sectoral response to FGM. So I'll stop there. Thanks so much.
Thank you so much, Christina. And it is wonderful that there are so many guidelines, and we need to make sure that they get to health professionals and they can actually make use of them. And I know there's a lot of work being done there. So I think my colleague Sean is also posting the guidelines in the chat, so for people to be able to look at them and to make really good use of them. So thank you so much, Christina, for sharing those. Maybe if I do a very quick follow-up question, if that's okay, is we talked a lot about medicalisation. Maybe if I can ask you very briefly to say, because I know that a lot of times medicalisation is talked about under the guise of it's somehow safer to do, but it's both dangerous and misleading. Could you tell us why it is dangerous and misleading very briefly, just to explain to participants?
Yeah, I mean, I think I just want to start by saying that we really keep a zero tolerance approach. And so that means no form of FGM is safe. It means that there's a risk of health complications for all of them. It is a completely medically unnecessary procedure. There's no health benefit whatsoever to medicalisation. And so if health workers are taking an oath to do no harm by doing any form of FGM, they're in fact doing harm. And they're violating the rights of women and girls who are subjected to FGM at their hands. And there are there's a strategy that's in place. I won't go into it because I know we don't have the time, but I can put it in the chat. But there is a global strategy, and there really is a need for different sectors to come together and work against this, because it is a supply and demand issue as well. So what happens at the health systems level, but also what happens at the community level is important in ending medicalisation. Thanks, Anush.
Thank you so much, Christina. Yes, it would be great to have it in the chat so people can also make use of that. So thanks so much for sharing all this with us. And we are going to move now from global norms and guidance from WHO and the global bodies to turn to the future of the health workforce and the importance of engaging the next generation of health professionals. And I would like to introduce Dareen Chiari. Dareen, I haven't actually checked whether I'm pronouncing your surname correctly, so hopefully I am. And I've got the updated bio in front of me. So Dareen is Liaison Officer for Sexual Reproductive Health and Rights Issues, including HIV and AIDS, for the International Federation of Medical Student Associations. It is one of the oldest and largest student-run organizations. It has a network of more than 1.5 million medical students in 125 countries, working on a variety of SRHR topics, including gender-based violence and FGM. So thank you so much, Dareen, for joining us. It's really important to have youth organizations, particularly youth health medical professionals, to engage with this important topic. So I want to kick us off by starting with a very straightforward question, Dareen, is what role can medical students and young doctors play in prevention of FGM and advocacy?
Thank you very much for having me. Hello, everyone. I'm Dareen, and I will be representing IFMSA, as Anush told us. So from an SRHR perspective, from a sexual and reproductive health and rights perspective, female genital mutilation is not only a harmful traditional practice, but it's a form of gender-based violence that affects bodily autonomy, sexual health, reproductive outcomes, mental health, and the overall trust in healthcare systems across the life course. So pre-service, education really matters for us as medical students because it's one of the most powerful yet misused or underused tools in female genital mutilation / cutting prevention. So medical students and young doctors are often considered the first point of contact for survivors, and most of the times it's really the only contact through the awareness campaigns and so on. So the way we are trained determines whether care is going to be safe, respectful, and rights-based, or whether it's going to become another source of harm and the cycle of violence continues. So if female genital mutilation is absent, minimized, or poorly taught in medical education, the healthcare system is going to continue being a disappointment for FGM survivors. And it becomes a barrier to prevention and care, which means that it's going to stop serving its initial service. Initial purpose. So what really, if I could summarize the role of medical students and young doctors, first of all, we are not only the future health professionals, but in IFMSA, we like to think of ourselves like the present day actors when it comes to prevention and advocacy. So first of all, as learners, we have a responsibility to understand female genital mutilation beyond the anatomy, beyond of what we're being taught in our medical curricula. So we have to understand it as a human rights violation, as a form of gender-based violence, and as a core SRHR issue. And then once the learning is done, we move to the advocacy part where students and young doctors can advocate within medical schools, within the hospitals, and within the policy spaces for survivor-centered human rights approach and non-discriminatory care. So this includes, but is not only limited to, challenging medicalisation, stigma, and the harmful narratives that silence the affected communities. And finally, through peer education, this is something that we focus a lot on in IFMSA. We have a lot of workshops that educate medical students about community engagement, about youth-led advocacy, about how to be an efficient advocate. For example, we have a workshop called Violence to Victory. It's a workshop that teaches youth, that is by the youth to the youth. We teach them how to properly advocate against gender-based violence. So when we're always in collaboration with communities, with survival-led movements, this becomes very efficient. So through IFMSA, this youth engagement is translated into global advocacy. And this is what we do in international forums like the Commission on the Status of Women, the Commission on Population and Development, and the World Health Assembly. So this links our local realities, our local efforts with international sexual reproductive health and rights and human rights standards. Thank you.
Thank you so much, Darine. Your words, and I'm going to read them. Being the present day actors, you have the responsibility to understand FGM beyond the health and anatomical aspect as a human rights violation. I think it stayed with me, and the role that you play within health system as advocates, it's really important, it's really powerful. Thank you so much for doing that, and thank you so much for hopefully encouraging more health professionals, young health professionals, to do the same. I know you're also working on a shift, so I have to thank all the people on this call who either woke up really early as Aparna, which is a really ungodly hour for many, and Darine working through the shift. So thank you so much for your commitment to this.
So
Thank
true,
you.
so true. And I always say you are the future, and medical students are our future. So a teaser is that in the next few weeks, FIGO, IFMSA, and Orchid Project will join hands together to kind of do a training, a virtual training to sensitize medical students across the globe, specifically Asia and Africa, to FGM, and that will be led by two of our next panelists who you're going to hear from. Thank you, Doreen. And I think from moving on from hearing about the future of doctors to the frontline practice, now you're going to hear from two of our frontline workers. First, I'm going to introduce Dr. Hannah Nasri. She's an OBGYN working across clinical care, research, and global advocacy. I met Hannah in many of these FGM related kind of workshops and panels that I've been to, and she's been inspiring ever since I first met her. She's the director of Malaysian Doctors for Women and Children, a core member of the UNFPA Malaysia FGM Partnership Committee, and advisory board member of the Asian Network to End FGMC. She holds many other roles, but I think today I want to ask Hannah. FGM in Asia is often invisible, Hannah, especially in global discussions. What's the biggest misconception about it, and what needs to change from the perspective of a healthcare provider to address it effectively? And you being the frontline worker, give us some perspective and help us navigate through this question we have.
Of course, I think FGMC in Asia is under-recognized because of two reasons, and one is the assumption that Asian practices are mild or purely symbolic. And this leads to the belief that they pose little harm. And in Southeast Asia, we know that medicalisation has shifted the practice from needling and pricking to the clitoris to cutting the external clitoris. So the harm reduction argument doesn't work at all. The second is recently reflected in recent academic debates. If you are aware of the BMJ ethics article on the harms of the current global anti-FGM campaign, is the idea that anti-FGM advocacy is driven by Western agenda and ethnocentrism. This suggests that our work is being shaped by Western donors, Western feminist framings, or Western human rights language rather than local realities. But what we see across the region tells a different story. Healthcare providers are responding to what they encounter in clinics every day. Families requesting for FGM, girls presenting with complications, and the ethical questions raised by medicalisation. And researchers and community leaders in Asia are generating their own data and articulating their own priorities. This is not about importing an agenda. It's about addressing the needs and responsibilities that arise within our own health systems. But at the same time, globally as well, including in the West, there is a growing discussion about whether non-medically indicated female genital modifications that are socially accepted should also be understood within the broader FGM discourse. This shows that the conversation is evolving everywhere, not just in Asia, and that societies across the world are re-examining how bodily autonomy, medical ethics, and gender norms intersect. From a healthcare perspective, what Asia needs is clinical literacy grounded in regional evidence, training, legal clarity, and culturally sensitive communication tools. When we center Asian data and Asian leadership, we move beyond minimization and beyond accusations of Western influence and towards a constructive and regionally led approach that protects girls and support providers. And I often say that nothing I've done is extraordinary. I think any resident doctor could have done the same. What shifted for me and got me involved in advocacy is a moment of professional discomfort. I was reading a paper on the medicalisation of FGM in Malaysia, and as a Malaysian, I feel deeply unsettled and even angry that a non-medically indicated practice was being normalised within a health system. So instead of letting that feeling go, I acted on it. I reached out to the author and started an academic forum simply by contacting medical colleagues on Instagram and LinkedIn, and the rest is history. But my point is it's really important to try and understand the nuances of the practice. And I did try very hard, and especially with the persistent myth that it is minimal and therefore less harmful. And what I found was that many clinicians across countries and specialties were asking the same questions, but had no space to explore them. So the catalyst wasn't exceptional courage. It was just recognizing a professional responsibility to question what we normalize and to bring evidence into the conversation and to create spaces where healthcare providers can engage openly with practices that are culturally embedded but medically unnecessary.
So true. And I think you say it in a lighter sense that it's not special, but I think it takes courage, and it takes like perseverance for us as healthcare providers to work on certain things that are not very commonly dealt with or met with opposition all the time. So kudos to you for working on this and working towards this in a in the setting where it's pretty much invisible. So really appreciate your work. Anush, over to you.
Thank you so much, Hannah. So moving to another frontline worker, we have with us Mariam and Nosa, and I met Mariam in Berlin a few months ago when we did a joint session together at the World Health Summit. Mariam, it's always wonderful to have you and to have you speak in these important places. So let me quickly introduce Dr. Mariam. Everybody has so many achievements, so it's very difficult to try to wrap up in a short introduction. So Dr. Mariam Ennose is a senior consultant gynecologist at the University Hospital in Germany, Gießen, Germany, where she leads the specialized unit for vulvar diseases in the FGM clinic. She is specialized in gynecological oncology, vulvar pathologies, and reconstructive surgery, with advanced training in microsurgical, clitoral, and vulvar reconstruction under Dr. Danman O'Day. She is also the chair of the Working Group on Women's Health in Development and Cooperation. Mariam has initiated international virtual FGM boards, a global expert platform for case discussions and knowledge exchange. She also co-leads Revolve Tanzania, a project providing reconstructive surgery for women with FGM. Thank you so much, Mariam, for joining us today. Can you talk us through specific progress that the German OBGYN Society achieved regarding FGM care in Germany? And how can we ensure that these advances in gynecological education, I know you're going to talk about that, are implemented and standardized across Europe?
Thank you, Anush, for introducing and for this important question. So first of all, to give you a background information about the situation in Germany, it is a country like any other European country that is receiving a lot of migrants, people who have survived FGM, and we are facing rising numbers every year. And this situation just makes clear that female genital mutilation is also relevant in the global north. So I'm speaking for Germany right now, and our OBGYN society has different working groups. And as Anush mentioned, I'm leading the working group for global women's health in international development cooperation. And we have been facing some big gaps of knowledge amongst our society of gynecologists. And this was due to lacking guided and structured training about this topic. So we have achieved not only, as Anush has mentioned, the global international case discussion boards where professionals can present anonymous cases and ask for diagnosis and therapy strategies and support, but also on the educational level, we have started developing curricular modules, something like an FGM curriculum, which is supposed to be a basic education for not only health professionals in gynecology, but also for midwives and medical students. And I think a very important achievement in Germany is as well is that knowledge about FGM is now mandatory during our medical education for medical students, but also midwifery students, and it's also a requirement to become a gynecologist. So I think this is some big achievements we have. Of course, it is important to have guidelines as well, but I think to strengthen these strategies, it is important that we all work together across borders in Europe, but also globally. It is important to develop networks for training centers where not only patient care
is a service, but also training the trainers is possible. So I think mixing all these methods and strategies, training the trainers in accredited training centers, and also going global on this is very important, and combining it with online modules, online learning. And I'm very happy Aparna has already mentioned that we will be hosting all together the first training for international medical students is a big achievement on that.
And
Thank
not
you
just
so
that,
much.
yeah, not just that, Mariam. I think we also want to do like these FGM boards globally, not just, in the German society. And I think that's one of the things that we talked about for FIGO to probably pursue in the future. So that is another thing that it's really interesting to see how Germany has done it. And whenever one professional organization does it, there is room for like other regional, national, and international organizations to work on it. So thank you for leading by example, and I really appreciate it.
Thank you so much, Mariam.
Thank you.
I think, that brings us to the quick summary of all the amazing panelists who gave us this wealth of information and a summary. And we really, first of all, want to thank all of the panelists for a great presentations. Now, I'm also very, very thankful for this such an engaging group of audience. I've been monitoring the chat and you've all been so engaging, and it's really lovely. Couple of things in the chat. May I invite all the panelists to come back onto the main podium? Thank you. There are some of the chats that we already answered. Fatu, thank you for answering the question about that was addressed to you. But I think one of the things that is here, one of the question is that what policies and enforcement mechanisms are needed to ensure that no healthcare worker performs or facilitates medicalized FGM, which FIGO and WHO identify as a serious ethical violation. I think we touched upon it, but do any of the professional bodies, or Christina, do you want to take that to see what would you encourage us? Like, how would we do that? What are some of the steps towards that?
I mean, I'm happy to start, and perhaps others want to jump in as well. Yeah, I mean, this is an important element. I mean, it's in the global strategy against medicalization. It's in our guideline that there's a need for codes of conduct for health workers. And so these go beyond what national laws and policies might put in place. But most of the licensing bodies for different categories of health workers include some sort of codes of conduct, and sometimes this is through the professional associations, and sometimes this is through national bodies, and so that can vary. But again, it is, so there's looking at it as a violation of rights, as a violation of laws, and as a violation of codes of conduct. And so through those different mechanisms, I think, I mean, there's also, within the human rights, there's also this important element, which is that health workers have a responsibility to uphold rights as well. So that kind of goes one step beyond, sort of adhering to laws, but ensuring that the people that they serve receive quality care, that their rights are respected, and that their rights are promoted, because they are what they call duty bearers within the human rights framework. So health workers are actually duty bearers to uphold rights. They have that responsibility. So any violation of that requires actions. I mean, countries have done different things. They've had, there's examples of, as people get their licensing, that they take oaths to not perform FGM in addition to their oaths to do no harm. There are ways that health workers can be fined. They could lose their licenses. They could experience criminal consequences as well. So there are options that countries can take and that professional associations can take and licensing bodies can take. So, I mean, I think that can vary and that can look differently in different places and depending on the different cadres of health workers. But I think there are options there, definitely. And, again, I think in those 2 documents that we've put in the chat on the global strategy and the guideline, there's some more information about these 2 topics, but it's a really fundamental question and an important topic. So I'm really glad that someone raised it. Thank you.
Maybe I can chip in, and I think professional bodies and societies probably have an obligation to push governments for law reform. And in South Africa, GBV is recognized as a crisis. And least recently, our president introduced a new legislative framework to address the problem of GBV. So I think law reform is quite important. Thanks.
So true.
May I come in?
Please.
Thank you. I think for us in the Gambia, this is very relevant. Right now, as many would know, we have a law that actually bans female genital mutilation. And over the past 2 years, we've been going back and forth on maintaining the ban. Presently, the ban is the conversation is at the Supreme Court, where they are actually looking in whether to repeal the law or not. And one of the big narrative, the big conversation is to medicalize FGM. You would also hear or may have seen that recently we lost 2 babies who died after being undergoing FGM. So people are arguing that if this was actually conducted in a medical facility through health professionals, the risk will be minimized. But we all know that FGM is not safe in any space, in any time or age. But I know that one of the consideration as we are reviewing the law is to look into medicalization. And my question again, especially to WHO, as I always say, Gambia is not an island. We are part of the international communities that have signed and ratified international treaties that ban FGM. How can we piggyback on these international legislations, or how can the international community amplify the fact that medicalization of FGM creates harm regardless? And yeah, I hope I'm making sense with my point.
Very much so. And I think it is so important that we all work together, and there's so much to even that non-medicalization is a huge issue, like saying no to even medicalization or any practices. And we all have to stand together and stay strong and keep saying the same thing 100 times or 1,000,000 times, because 100 ain't gonna do anything here. So definitely, and thank you for this rich discussion. Maybe one last question that was there, which kind of caught my eyes. Was from Isatau Sar. Thank you so much for posting these questions. I'm hoping that some of these are being answered as we are speaking about it. One big question was in addition to prevention, how should healthcare systems integrate mental health services into this reconstructive surgery and access to trauma-informed support for FGM survivors? Anybody want to take on that? Because I think it's a very important thing to address, and it can cause long-lasting mental health consequences.
I think I can answer on that. It's a very important topic to look at all this a bit more global, that reconstructive surgery does not only mean to repair a body. It has so much impact on the body picture, on the well-being, and psychologically it can make a big difference and a lot of changes. So it is very important to include psychological, mental health care support in this whole treatment plan. And I know this is quite often a challenge. Even here for us, it is not so easy to implement that, but it is definitely important to include that and to screen for mental health and psychological impact after the cutting.
So true. Yeah, Christina.
Yeah, if I could just, I completely agree with Miriam, and just to add to that, that there's, in the context of when clitoral reconstruction occurs, that it needs to occur in the context of sexual health counseling to accompany it, to precede it, and to accompany that, and that it's more likely to have positive outcomes if this sexual health counseling occurs as well, recognizing that women's sexual health is it's not just an anatomical fix to the issue, but that it's a much broader kind of approach, holistic approach to women's psychosexual health as well. And I also completely agree that the mental health complications are also an important aspect, and this is included in our guideline. It's a priority topic in the guideline that we've produced as well. So yeah, I think we have that posted in the chat by now, so people can also refer to that. Thanks.
All right. In the interest of time, I think we should wrap up. Anush?
Thank you so much, everyone. Thank you for our wonderful panelists and speakers. I know you had so much more to share, and sorry for keeping it so brief, but I think it was wonderful. So pleased and so grateful to audience as well for so much engagement. And what we will try to do is to look if there are any questions, maybe try to respond if possible at all. We'll figure out on our technical side if there is anything that we left unanswered. But I just would like to really thank so much everyone, and again reinforce the importance of multi-stakeholder cooperation and working with health institutions, with civil societies, with governments, with activists and survivors, or what we call them, experts through experience, to work together towards ending FGM. And over to you, Aparna. Thank you so much.
Yeah, a huge thanks to all the organizations. I'm so thankful for FIGO, WHO, IFMSA, Orchid Project, all of you. And humongous thanks to all the panelists. I know how difficult it is to carve time out, especially in this time where everybody has so many other obligations. And I think, yes, the core is to emphasize the role of like synergy in multi-stakeholder partnerships and all of us working together. I would say this is just the beginning, and hopefully we'll bring in before the next year, there will be some more significant work that we could do to put another dent into ending FG. All, and we really appreciate everyone, and thank you, wonderful audience. I've been seeing the chat and it's been so engaging. I really appreciate all of you, and hopefully we'll put in the information about the medical student train. If you can disseminate across our networks and have more students join our training program, which should be in the next couple of weeks, look over this in our social media. Thank you again, everyone.
Thank you.
Thank you. Bye.
Thank you.
Thanks, everyone.
Thank you. Bye-bye.
Bye.
Thank you.
Goodbye.
Bye-bye.
Letter will the recording.
We